but I have the pleasure of introducing Paul Riley, who I know for quite a few years in the field. Paul received his Bachelor of Science, his undergraduate training in Seattle, just close by, and did some research technician type of work for a couple of years, I think. But then went on to do a PhD in biochemistry at Temple University in Philadelphia in the field of coagulation, and then did a postdoc where was that? So I can't remember now. In the, but actually did similar work, but did some high throughput screening and a variety of other things. I think that's where he sort of acquired a more a quasi business acumen at that time.
Right.
Then soon after, I'm not sure if it was directly after, but soon after joined Stago in the product marketing field, had a variety of roles and rapidly moved, quote, up the ranks, where now he is the scientific business development manager for Diagnostica Stago, and acquired an MBA along the way at Cornell. He's really although he's certainly a business person, but he's certainly an academician as well. He's very active in the academic community. We know him well. He's very supportive, always providing really valuable insights, particularly for us in the coagulation world. Has always been very supportive. As a matter of fact, Stago in general has been very supportive, particularly about the Center for Blood Research, but I know elsewhere, and he's always at international meetings that are relevant to us. So it's really a pleasure to introduce him. Title of his talk is Disseminated Intravascular Coagulation, the Critical Role of the Lab. So Paul, it's all yours, and we're looking forward to it.
Okay, great. Thank you so much, Ed. That was such a kind introduction. I appreciate, I really valued working with everybody too at CBR and visiting with you when I've been able to do that in the past. Okay, I'm going to start sharing my slides now. And okay, so hopefully you can see my screen.
Yes, perfect. Just to encourage everybody to
overview of coagulation.
Right, just to encourage everybody to send in questions, but we'll open it up as well at the end. Okay, go ahead, Paul.
So, yeah, I don't want to belabor this particular point, but just as a reminder, coagulation is very much of a balance between procoagulant and anticoagulant factors. That where the business end is thrombin formation, and then the subsequent formation of the fibrin clot in response to injury. But then this process can obviously happen on a pathological basis in many disease states that we'll be covering today. So just as a reminder, the fibrinolysis produces the endpoint of plasmin, and then that plasmin will then go on to digest fibrin clots as a response to recent clot formation in the plasma. And that's normally a good thing when you want to get rid of a fibrin clot and then have the wound healing process to happen. But then again, this will happen under pathological circumstances as well. So again, the fibrinolysis cascade, through either the extrinsic side through production of TPA from endothelial cells or production of urokinase within the intrinsic pathway of plasma, produces the plasmin again as an endpoint of this pathway. The plasmin digestion of fibrin clots produces not only fibrin degradation products, but specifically the D-dimer product, which is something that can be used as a diagnostic tool for understanding recent clot formation in the plasma, and also can be used as a diagnostic tool to understand ongoing thrombosis risk and seeing the progression of a disease state in a patient who has ongoing clotting in a hospitalized condition, such as the disease state that we'll be talking about today. So fibrinolysis again releases the D-dimer product from the plasma, and basically, if you have D-dimer presence, then that means there was fibrin clot formation recently, and then that digestion happened in the patient's body. But then if you have a normal D-dimer, that means there's most likely no thrombosis formation recently in the patient, and then it should indicate a patient who can be discharged or doesn't need to be admitted to the hospital in the first place. So, again, the D-dimer is an end product of the digestion of the fibrin clot, but just showing the different proteins that are involved in formation of D-dimer. You have first fibrinogen getting activated by thrombin to the fibrin clot, but then the intermediate in that fibrin clot formation is the fibrin monomer particle. So the fibrin monomer appears before you have a thrombosis in the plasma, because thrombosis is really the production of the insoluble fibrin clot that's been cross-linked by factor 13A. And then a digestion of that fibrin clot then results in D-dimer as well as other fibrin degradation products. But for this talk, it's important to just recognize that the D-dimer is really the later part of this pathway, and really the earlier part that might indicate a pre-thrombotic issue is that fibrin monomer formation. So going to the main subject of this talk, which is disseminated intravascular coagulation, it's defined as an activation of coagulation all over the body where you have clots forming in multiple locations, especially in the microvasculature. And then consumption of different clotting factors that are being activated through this activation process leading to DIC results in consumption of those factors and then a bleeding symptom in the patient. But then the patients who have DIC often have both a clotting and a bleeding symptomology. So it's very confusing for clinicians. They might not be able to recognize DIC when it's happening in the patient because there's so many different unrelated diseases that can trigger this condition. And then there's from patient to patient, there's going to be quite a difference in the presentation of the symptoms. And then there's not really a good consensus, especially here in North America, on how to diagnose the DIC from the laboratory point of view. And then there's not a really good consensus on how to manage the patients either. So there's many different conditions associated with DIC. You can see a list of them here. So they involve a sepsis or infection, but they could involve many other things such as trauma, and then organ destruction, but also organ transplant rejection can also lead to DIC. And then there's several different cancerous states that can lead to DIC, as well as obstetric issues, and then other vascular abnormalities or liver failure, snake bites, recreational drug use. So all these things can produce a DIC, and it's really something that doctors may not be aware of, and that's something that you really should be looking out for in patients who have these conditions. So this slide shows what's happening in a Purpura Fulminans patient, so who has DIC due to an underlying sepsis from meningococcal infection. And then Purpura Fulminans is a hematological emergency when you have skin necrosis and with DIC, and this can lead rapidly to multi-organ failure caused by thrombosis and occlusion of small, medium-sized blood vessels. Then, so the pathophysiology of DIC is here. So you have this underlying disorder from that list I showed before that leads to activation of coagulation. And then you have a deposition of fibrin, microvascular thrombosis, and then organ failure. But then at the same time in DIC patients, you can have consumption of platelets and coagulation factors leading to a very low platelet count and then leads to bleeding. So you have this paradoxical situation of both thrombus and bleeding in the patients. And in COVID-19 patients, we see some condition that's related to DIC. It's not really exactly the same thing, because in COVID-19 patients who are severely ill, their platelet count goes down slightly, their coagulation factor levels may drop slightly, but they don't really see the bleeding issues in those patients. What we see more often in COVID-19 patients is the thrombosis that can form extensively throughout the body, especially in the lungs, leading to death from that condition. So in this particular summary of different disease states and the frequency of DIC in those states, you can see here that sepsis as well as trauma can, in those patients, you can have a pretty high frequency of DIC in those patients, and then a lower frequency of DIC in metastasized tumors. But then when in women's health disorders where you have amniotic fluid embolism or some complications of childbirth late in pregnancy, you have DIC happening in 50% of those patients. And then even preeclampsia will give some frequency of DIC if the preeclampsia is not recognized and treated quickly. And then this study, it was a survey from Japan that was published back in 1997 originally, but they looked at an incidence of DIC, underlying diseases, in many different divisions and departments of different hospitals around the country in Japan. And in a little over 2,000 patients, you see that the percentage of patients with different infections and tumors accounted for 28% of the DIC cases for those patients with infections, and then 23% of the cases were from patients with tumors, including leukemia patients. So the DIC, if you have DIC, right, that then you have a higher chance of mortality. So this is another study from Japan where they've done so much work to characterize this disease state, and they see with patients with DIC can have a 35% mortality compared to those without. And then even patients who have a pre-DIC state versus DIC, those, there's a resolution rate. So the pre-DIC patients can actually recover in a higher frequency compared to those who have already progressed to DIC. So it's important to catch this disease state early and not allow it to progress too far. But in patients without DIC versus those who are in a pre-DIC condition, the mortality rate is lower in those patients without DIC. So again, just showing how important it is to catch this in an early stage of the disease progression. And then patients who are older tend to do worse in this disease state. So you see just a generally increasing mortality rate for patients as they age, and so the patients with DIC who are older, tend to do worse, and then the non-DIC patients shown in gray bars are doing a little bit better in this reflection of mortality. So I showed this already. So just trying to show how you have this widespread condition in the DIC that can lead to both a thrombotic and a bleeding situation. And then there's different types of DIC. So you can have a procoagulant DIC that's predominantly thrombotic, where you have a more proportion of a coagulation pathway activation compared to an activation of the fibrinolysis pathway. But then you have another type of DIC, which is subclinical, where you might see some laboratory testing changes, and then some equal extent of coagulation pathway activation versus fibrinolytic pathway activation. But then you also have a potential for hyperfibrinolytic DIC, where you have a great deal of fibrinolytic pathway activation, and then those patients could have a very, very high D-dimer level because of that hyperfibrinolysis. But then they're also going to do poorly in terms of a bleeding outcome, because they'll have such a consumptive coagulation issue going on, and then also a low platelet count. And there's an interaction of the inflammatory pathways in the body as well as coagulation when you have sepsis. So a binding of tissue factor, that's getting released from the different inflammatory cells, and then a thrombin, and the binding of those things to protease activated receptors on platelets, fibrin to TLRs on inflammatory cells. That leads to inflammation activation, and then you have a release of different pro-inflammatory cytokines and chemokines, and that will impair the different anticoagulant pathways that we have, such as the activated protein C pathway, and that leads to to unregulated coagulation. And also those pro-inflammatory cytokines, chemokines also will lead to shutting down the fibrinolysis pathway as well. So, so you can have these very strong, crosstalk between the inflammatory and coagulation cascade that leads to some bad outcomes for the patients. So we see here just a representation of what's happening in sepsis patients. And so those pro-inflammatory cytokines that were activated by the sepsis condition in the presence of bacteria lead to tissue factor expression from monocytes, and those tissue factor bearing microparticles, which now are referred to more as microvesicles, lead to some activation of coagulation, fibrin deposition, and then production of a microvascular thrombosis. And then you might have insufficient removal of fibrin deposition because of the PI1 getting released from activated endothelial cells. And again, so those different pathways coming together can lead to a potentially bad outcome in the patients. So the DIC will also result in organ failure because of fibrin deposition in microvasculature parts of the body. And this figure shows a little bit more about what's happening here. So that vasodilation that's resulting in a lower blood pressure and then a decrease of red blood cell deformability leads to some tissue hypoperfusion. But what was happening before that was, again, some expression of tissue factor from monocytes that were activated in the sepsis condition. And then these neutrophil extracellular traps with trapped platelets will then form around a thrombus and lead to, again, a thrombosis and then a further hypoperfusion of the tissues. And then that lack of tissue oxygenation then leads to organ failure in the patients. And so again, catching this whole process earlier than later leads to a prevention of the organ failure in these patients. So again, so you have this blood activation with endothelial lysis, tissue factor expression, and then thrombosis formation, formation of fibrin, and then the plasmin coming along to help digest the fibrin clot then leads to a formation of D-dimer. But then the consumption of the different coagulation factors also leads to bleeding. So in this stepwise model here, with DIC, you have a first step with abnormal activation of the coagulation, again through damage through the blood vessel wall, release of TF, activated cells that are getting pulled into the immediate area, resulting in deposition of fibrin, and then the morbidity and mortality from microthrombosis that can happen throughout these different vessels. And then the second step or later stage of the DIC can lead to consumption of the coagulation factors and also the inhibitors that are trying to control the coagulation cascade, as well as platelets. And then you have DIC and the increased D-dimer, but also a bleeding at the same time. And then again, it's just another representation from a publication showing that you have not only intravascular deposition of fibrin, but also at the same time depletion of the platelets and the coagulation factors, leading to those bad thrombotic or bleeding outcomes. So there's two actual clinical pictures that are in these patients with DIC. So there's a chronic or a non-overt DIC that doctors may not be able to recognize clinically, or they might be relying on their gut feeling to diagnose that chronic condition. But then when the DIC gets to a more acute or an overt stage where you have a bleeding and organ failure, that's really where the patient's in a great deal of danger. And you have to do a clinical diagnosis in the overt DIC, and then you need the laboratory tests as well to look at what's happening with these, to see if they're non-overt versus overt DIC, and then also to try to figure out if the treatments that you're doing are efficacious or not. So with overt DIC, you have strong generation of thrombin, leading to all these different issues I was talking about. But then with at the stage of overt DIC, you also have this strong generation of thrombin, a generation of plasmin, leading to then hemorrhage and different bruising and petechiae or different bleeding, different venopector sites or in surgical wounds. And then that inflammation is very much linked to coagulation as you go through these different stages of the DIC. So in terms of the diagnostic approach, you can use the International Society of Thrombosis and Hemostasis, their step-by-step algorithm to first figure out from the clinical side, is there an underlying disorder that's known to be associated with DIC? And so if the answer to that is yes, then you can go and look at the platelet count from the laboratory, and then if it's a lower platelet count of less than 50,000, that gets an additional a score of 2. And then if you have fibrin degradation products that could include D-dimer, then you have and if they're strongly increased above some criteria that you establish locally, if those D-dimer levels are strongly increased, that adds an additional account into the ISTH score. And then additionally, the prolongation in prothrombin time, and then decreases in fibrinogen level will add in some additional score into this algorithm. So there was also a validation study performed with this ISTH DIC score at Texas Children's Hospital in Houston, and they compared their own in-house derived score in 2,136 DIC panels that they had looked at retrospectively from 130 pediatric patients. And what they found was that the ISTH score that they established then had a higher receiver operator characteristic curve, so a higher sensitivity and specificity, that meaning that the ISTH score does have some validity to diagnose DIC patients, more so than their own in-house criteria. So again, with the DIC management, you need to stop the underlying disorder and but give some treatment to stop the inflammatory DIC from happening, and also stop the insults that are leading to further thrombosis formation, and in order to get the patient over to the recovery side of this equation, rather than leading them down the pathway to the mortality outcome. So with the goal of the DIC management and their treatment, you want to stop the activation process. You want to give some thrombin inhibitors, and potentially plasmin inhibitors, but more likely it's usually more thrombin inhibitors that are given, such as unfractionated heparin, and then low molecular weight heparin can be given as well. But then you also have to look at the antithrombin levels in the patients to make sure that those antithrombin levels have not been consumed in the patient, and that the unfractionated heparin that you're giving is going to be effective. And then due to the decrease in the coagulation factors, to monitor heparin administration, if that's been given, you can't really use the APTT because it's going to be affected by those low coagulation factor levels. Instead, you would have to use a chromogenic anti-10A level in the clinic in order to monitor the heparin and make sure it's in the right therapeutic range. So oral anticoagulants such as warfarin can be considered once the patient stabilizes to prevent a further clot formation. And I don't think the DOACs have been validated for DIC use yet. And then you can also give vitamin K supplementation potentially if the patients are exhibiting an acquired vitamin K deficiency, which could happen, if their gut bacteria is out of balance, or if they're consuming the coagulation factors too much, leading to an acquired vitamin K deficiency. And oxygen can also be given to the DIC patients to correct hypoxia and prevent that organ destruction from happening. You would have to look at markers of thrombin as well as plasmin generation to really understand the balance of DIC in the patients. Generally what's relied on is the D-dimer test, because that's pretty widely available in almost all hospital laboratories to test for DIC. The problem with the D-dimer, it's not a very specific marker in general, but it has a very good rule out capability to figure out who doesn't have thrombosis. But in DIC, you're trying to look at more the D-dimer in more of a rule-in status, where you're looking at elevated D-dimer as a reflection of both the activity of thrombin and plasmin. If the D-dimer is negative or below the cutoff value that was established, then there's a very low probability for DIC. Generally, hospitals don't try to develop a DIC specific cutoff value. They'll just use the cutoff value that's being used for thrombosis exclusion in emergency room patients. So what might be helpful is to add an additional assay, such as a fibrin degradation product assay. Those have been traditionally done with card or manual assays in the past. It's also possible to use a specific automated fibrin monomer assay to look at this condition in a more to look at the more early formation of thrombin and look at the fibrin monomer that's happening in the earlier part of thrombosis formation. Some older studies have shown that you need that really one test is not sufficient. So you can see here that your traditional clotting tests, such as PT and PTT, have a high sensitivity for DIC diagnosis on their own, but then they have a relatively low specificity. And then so what you need is a combination of PT with PTT. And then in this study, they found that the PT with the PTT and the fibrin degradation product, gave some relatively high sensitivity and specificity. And then, combining the FDP plus a D-dimer test led to the highest sensitivity and specificity profile in this particular study. So the FM is a predictive, potentially a marker, because it's appearing earlier before you have thrombosis onset, and that's due to the fibrin monomer being in the earlier part of the thrombosis formation. It's something that appears after fibrinogen's been activated to fibrin, after removal of the fibrinopeptides. So the FM, it could be a predictive marker, and it's been used in East Asia for many years for this purpose. And it appears 0 to 3 days before you have onset of thrombosis, but it has a relatively short half-life, a little bit shorter than D-dimer. So D-dimer is appearing later because it's something that's happening after plasmins come along to digest the fibrin clot. So the D-dimer has a little bit longer half-life, but again, it's just early. It's later appearing. If you're doing a FDP or a card assay, or there are automated FDP assays available in the East Asian market, those FDP and D-dimers will appear around the same time. So again, the fibrin monomer, or here it's shown as a soluble fibrin monomer, or SF, in this particular figure, that's again appearing earlier, and it could be much more useful for the clinicians before the patients get into a worse thrombotic state. So there was a prospective study done in India that was published, back in 2017, and the study from these patients compared the chronic DIC to, and they also did a separate graph of the non-DIC patients. And in this study, they showed that comparing those chronic to the non-DIC patients, the FM was outperforming the D-dimer on this ROC curve. So the area under the curve was a little bit better for the fibrin monomer in this group of patients. And then in a different Korean retrospective study, the fibrin monomer was assessed, and then you also see some conflicting results here. So the area under the curve in this representation was a little bit higher for D-dimer in non-overt or chronic DIC patients, but then you saw some higher area under the curve for a fibrin monomer in acute or overt DIC patients. So just looking at the left panel versus the right, it's basically there's not much of a difference, I guess you could say, from these data. So I mean, really, it might be useful then to validate both of these in a hospital setting, and then have them both available to be able to differentiate the different types of patients according to your local criteria. And then a different study from the UK from 2013, they showed that there's the different trending patterns for markers of DIC in these different types of patients. So generally the sepsis patients, no matter whether you're looking at an automated FDP test or an automated FM or an automated D-dimer test, those sepsis patients generally had much higher levels of those different markers compared to the normal or the non-infective systemic inflammatory response syndrome patients. So basically, if you have D-dimer, FDP, or if you have FM available, those can help you to differentiate your ICU patients that are in the hospital with and without sepsis. And then we see here from the same study that the FDP, the FM, the D-dimer, those all are in a trending decrease pattern for patients who have a survival outcome after 28 days. So this is really interesting because just at the beginning of their hospital stay, you have a downward trending in those three markers for an outcome of survival. But then with the patients who have a mortality outcome, the FM still showed a trending decrease at the beginning of the hospital stay, whereas the FDP and the D-dimer were both trending upwards at the beginning for those patients with a mortality outcome. So this is arguing that you probably need more than one test minimally to figure out if the patients are going to have a negative mortality outcome. And then in this study, which was published a little bit more recently, they have a comparison of the D-dimer and fibrin monomer versus other global hemostasis methods, such as a thrombin generation method run on a Siemens platform. They also looked at fibrin generation and an overall coagulation potential, which they determined by an in-house method. And they looked at different thrombosis patients and then matched those patients to controls who did not have thrombosis. And what they saw was the D-dimer showed a higher ROC curve, so higher sensitivity and specificity, combination in that area under the curve. But then the FM was still higher than their different global hemostasis tests that they included in the study. So again, arguing that you probably need both the D-dimer and FM available to be able to differentiate these patients who have thrombosis. And then another study of patients with progressive hemorrhagic injury who have started with a trauma to their brain. You have different situations happening here. So with the FM levels at admission, they showed that there was some fair accuracy to compare the patients who had the hemorrhagic injury versus those who didn't. And then so the FM was trending or adding to the picture for those patients with this trauma-induced coagulopathy if they ended up getting that while they were in the hospital. And then the FM levels were very high in these patients who had this injury of more than 131.7 microgram per mil, which is on the upper end of the linear range of the assay. And then a different study from China in a retrospective cohort that they looked at with 162 patients with acute ischemic stroke who were admitted to the hospital. You saw that fibrin monomer was a little bit more effective on the ROC curve to diagnose patients who had the acute ischemic stroke versus those patients with D-dimer. And so the FM and the patients with this acute ischemic stroke, that FM level was trending much higher, but there was a quite wide degree of variability between patients, and depending on their disease progression. But those FM levels in those stroke patients were much higher compared to a healthy group. And then the D-dimer, you can see here, did have some difference versus a healthy group, but then the D-dimer levels were generally much lower compared to the FM levels. And then when you combine the fibrin monomer, as shown in this study from China, the same study, when they combined the FM with an NIH stroke scale score used locally, that allowed them to differentially diagnose the diagnosis of the patients who had a stroke related to cardiogenic underlying reasons versus non-cardiogenic acute ischemic stroke. So your AUC for the FM group was 0.717, but then if you add in the stroke scale score, you get a little bit of higher bump on the fibrin monomer area under the curve. So and the D-dimer plus that stroke score had a little bit lower result on their AUC calculation. So this is similar. When we use D-dimer for excluding a thrombosis in ER patients, we tend to use D-dimer with a scoring algorithm such as well score. Then those scoring algorithm together with the laboratory test really provides a diagnostic ability for the clinicians to be able to exclude the thrombosis in a very accurate and robust fashion. And this similar thing is needed here with FM. You need a combination of FM with some kind of scoring algorithm, depending on the disease state, and then and that's similar to the other clinical conditions. There's some commonalities between COVID-19 and DIC, but you see a little bit different presentation in COVID-19. We see some mild thrombocytopenia in patients with COVID-19 because with DIC you have a much more profound thrombocytopenia usually observed, and then much lower levels of coagulation factors, as well as severely decreased levels of antithrombin and protein C in DIC patients. But then so the patients, if you try to use the ISTH DIC score in the COVID patients, those DIC scores would not tend. Okay, it's back now. All right, so I was trying to compare and contrast the COVID-19 with the DIC. So again, with the COVID-19 coagulopathy, it's mostly a prothrombotic manifestation with thrombosis that is generally in the venous system, but also in some patients it's also presenting in the arterial system as stroke. And then there's very few bleeding complications usually seen in the COVID patients. So basically, according to these authors, we should conclude that COVID-19 coagulopathy is a specific form of the intravascular coagulation, and then pretty distinctly different from DIC. And then, just showing how fibrin monomer relates to the rest of these different tests. We have a user, there's a Emory's coagulation lab in Atlanta. They're actually running the fibrin monomer as part of a panel of tests, including a D-dimer prothrombin fragment 1.2, as well as thrombin antithrombin. And when they looked at the hospitalized COVID patients, 276 of them, and what they found was that each of the markers, when they compared them independently, they were independently associated with a thrombosis endpoint. And then also, if you had greater than or equal to 2 of their MOCHA abnormalities in their panel, those greater than 2 abnormalities would be generally associated with both ICU admission as well as being intubated in the for severely COVID or severely ill COVID patients. All right, so just summarizing what I presented, the DIC is very heterogeneous between different patients. It can be rapidly fatal, and you have systemic and simultaneous activation of both the coagulation and the fibrinolysis pathways, leading to consumption of coagulation factors. And you have to use multiple tests, preferably a panel that includes minimally D-dimer as well as the fibrin monomer, according to many different international studies. But then, like the MOCHA panel that's being used at Emory can provide additional information as well. So the different screening assays that are performed in the coag lab will help to guide the initial diagnosis in a non-overt patient, as well as the platelet count, and then the fibrin monomer and D-dimer then can be used to stage the disorder, as well as figure out whether the treatment that you're giving to the patient is efficacious or not. And then in the COVID patients, as I showed, there's some similarities with DIC, but then some differences leading to different ways you could score DIC or the COVID-related intravascular coagulation. Okay, do we have any questions?
Anybody have any questions at this point? Were you going to wrap up? Is Paul?
Okay. I mean, do we have any similar research projects happening at CBR on these different types of patients that I was talking about?
Do you want to take off your slides and we'll see, we can open it up a bit and see if anybody jumps in there. No, I mean it's interesting to listen to. I mean, it's been a while since I was in the clinic, so and
Mhm.
but cruising through the literature, I can see that not a lot has changed in the management of DIC. The
Right.
challenges remain. It's a complex, multifactorial disease, obviously, or multiple causes, and the major emphasis is obviously on treating the underlying cause, and monitoring these patients is a challenge. And managing them too. And even with the advent of new the thrombin and 10A inhibitors, I don't know if it's changed much. Um, um, Jeremy Wood, though, does have a question. Jeremy, do you want to speak?
Yeah, I can
There
add.
you go. Yes. Hi,
Um,
Jeremy.
so I was wondering, how does the level of DIC that you're seeing in COVID patients compare to other severe respiratory diseases like ARDS?
That's a good question. I believe it's fairly similar, but you again with the COVID patients, you don't see as much of a bleeding manifestation. I believe with ARDS, you still see both the presentation of thrombosis and bleeding.
Okay, thank you.
Sure.
I think really ARDS still, from a definition point of view, is limited to the lung and is not. You don't have to have DIC with ARDS, and similarly, you can have DIC without ARDS.
Mhm.
So there, from a clinical point of view, there's probably a distinction, Jeremy. At least that's my recollection from my days in the ICU.
Thanks.
Okay.
I was just asking because there are often some level of coagulopathies in
Yeah.
ARDS
Yeah,
patients.
and undoubtedly it's probably always present, not always manifest by the measures that we typically do, but probably by, certainly I would expect D-dimers would be elevated in those patients inevitably, even without, say, prolongation of PT, PTT, and not necessarily changes in platelet counts, which can vary in any case. Yeah. Any questions? Ed Drysdale, you've demuted, I can tell.
Yeah, they demuted me for bad reasons, probably. Paul, thanks a ton for joining us today. I'm very interested in this idea about differential roles that coagulation and fibrinolysis may have in DIC, different extents of playing in the disease. And I think that this would be really important for physicians to understand and maybe alter treatment in individual patients. So I'm
Sure.
wondering why ROTAM and TEG might not be playing a bigger involvement in the clinic, because you can start distinguishing maybe some fibrinolytic versus procoagulant roles in these contexts.
That's a good question. My impression with TEG is it's not quite sensitive enough to pick up these manifestations, and it's not really considered a substitute for a D-dimer then. So, but I guess TEG, you could pick up that fibrinolytic shutdown if it was happening in these patients too. So it should play a role. I just, I haven't looked into it as much for these patients.
Yeah, also in the context of white cells and platelets, you might be able to glean some information. I've also had some discussion with some of our physicians here, and in particular, Andrew C, about altering what we use ROTAM for, or TEG, and I've been thinking about doing some plasma-based assays, but starting with normal deficient plasmas and then adding patient plasmas back, so that we can start picking these apart in a more quantitative and more defined manner in the clinic. And maybe that'll even add more, especially in the context of fibrinolysis versus coagulation effects in trauma or DIC.
Right.
And anyhow, just to add to the discussion of today's nice talk. Thank you very much.
Thank you. Yeah, that I think the role of TEG could be important for sure, these patients, but I think they just generally rely on lab tests, and then TEG is only involved really when you have a surgical event happening.
Yeah, it's so fast to do. Another advantage. Yeah.
Yeah. And then there was a question from Dieter Brome about how this compares to vaccine-related vascular side effects. I mean, the the vaccine-related side effects that I'm most familiar with respect to thrombosis are the vaccine-induced thrombotic thrombocytopenia. So the webinars that I've seen about VITT and other, some publications that I've breezed through, I mean, mainly that resembles heparin-induced thrombocytopenia much more than DIC. So with those, with the patients who have that side effect, and I think it's rare, right, that it happens, but it's primarily from the AstraZeneca vaccine, and then maybe also the J&J vaccine, but it's not related to those mRNA-based vaccines. But yeah, from my understanding, it's you have a severe platelet count drop in those patients. You do have a high D dimer level, and then they rely on looking at some anti-platelet factor 4 heparin antibodies that are used to diagnose heparin-induced thrombocytopenia. So those OD and the plate assays for heparin-induced thrombocytopenia are very, very high. And then those patients will have some clotting disorder that could be very severe, even in the brain where they have these severe clots. So these cerebral venous sinus thrombosis. So yeah, anyway, but so it's pretty different in this presentation from DIC.
Yeah, thanks a lot. And any idea why the DNA-based vaccines may have a different effects than the RNA or mRNA-based vaccines?
Yeah, there was a good webinar by Yves Grill I watched last week where he was talking about this. It seemed that there was some components of the adenoviral vector that seems to be producing some autoimmune response in patients. But it's pretty unclear, but it's because of that, they gotta have that adenoviral component to it. It's the mRNA vaccines don't have those adenoviral constructs in them. They're just mRNA surrounded by liposomes.
So, I mean, is it really excluded that, let's say, accidental expression of spike protein in the vascular system, endothelial cells, if the vaccine gets into the blood system? So they should be expressed in the endothelial cell, right? I mean, it doesn't matter if it's DNA or mRNA based.
Right. I'd have to refer you to those experts for more on that.
Okay. Okay, thanks a lot.
Yeah, and then there was a question about netosis. I mean, I talked about nets really briefly in one of the slides, so I think it's definitely a good idea if you had an assay for neutrophil extracellular traps, and you could certainly use that if you had some access to DIC patients. So I think it's definitely an open research question. And those nets play a role on the more on the organ failure side of DIC, from my understanding.
Other questions? I mean, it's still interesting that from a therapeutic point of view, even though we think we have a handle on, or sort of a handle on the mechanisms, that there's thrombin, generation is the primary player, that we're not a heck of a lot better in terms of, aside from the treating of the underlying disease and stopping DIC once it's underway, with thrombin, and whether it be combinations of thrombin and 10A inhibitors, although I think there's some preclinical studies, but preclinical studies haven't translated into clinical studies of great, with great results. So it's a curious problem. Continues to be a challenge.
For sure.
Any other questions, comments? Well, if not, Paul, thank you very much for that fabulous presentation. It's really always a pleasure to hear from you. We always look forward to interacting.
All right, great. Thanks so much, Ed.
Yeah, no, we appreciate it very much. Okay, so everybody else, and you, Paul, obviously, you're welcome to join us at the Earl Davey Symposium. Don't forget to be there. It'll be a fabulous day and certainly relevant to Stago as well. All right, good. Everybody, take care, be well, and we'll see you soon.
Okay, great.
Bye.
Okay.